We all know someone who fits a certain profile: the cynic, the stubborn realist, or maybe that friend who operates on a permanently low battery, coasting through life with a quiet, persistent flatness. If you ask them, they will tell you they have simply always been this way. Society readily accepts this demeanor as a permanent fixture of who a person is. Friends chalk it up to temperament, and family members view it as a fixed philosophical outlook on life. But there is a biological trap hiding inside that assumption. What we readily dismiss as a deeply ingrained personality trait is often a measurable physiological illusion. When a chronic medical condition is mistaken for a core identity, it creates an invisible barrier. It is the exact mechanism that keeps millions of people walking through life carrying a heavy, muted weight, never once thinking to ask for help. Look at this population matrix. Exactly 1.5% of these dots are illuminated, representing the share of U.S. adults actively experiencing persistent depressive disorder, or PDD. Because there is no dramatic before and after to signal a break from health, millions of people never realize they have a condition to treat. Without a point of comparison, they assume their daily baseline is simply the reality of their personality. Severity is usually what sends people to a doctor, but in this case, chronicity acts as a perfect camouflage, allowing a clinical illness to hide in plain sight for decades. This split graph breaks down exactly how PDD breaks the standard medical model of depression. On top, you see the dramatic, fluctuating sine wave of major depressive disorder, marked by distinct, severe episodes. Below it is PDD, a steady, continuous, low-level line. To meet the clinical threshold for PDD, that flat line has to stretch out across a strict timeline. We are looking for a depressed mood that persists for most of the day, more days than not, for at least 2 consecutive years in adults, or 1 year in youth. As the timeline extends, the individual will experience at least 2 ongoing secondary deficits, like chronic insomnia, a lack of physical energy, pervasive low self-esteem, or a lingering sense of hopelessness. The defining rule of the diagnosis is consistency. If there is a brief upward spike into a normal mood, it is fleeting. The symptoms must drop back down before crossing a 2-month window. There is no sustained relief. When a patient meets these strict criteria, it proves their daily experience is governed by a distinct, measurable physiological state. It is not a personal failure, and it is certainly not a character flaw. The hardest part to reconcile is that people with PDD remain highly functional. They hold down demanding jobs, raise children, and navigate complex daily obligations without ever experiencing a total collapse. Instead, they operate with a permanent dimmer switch turned down on their lives. The energy, the joy, and the cognitive focus are all just slightly throttled, constantly running at 50% capacity. The medical system struggles with this presentation. Because the symptoms have been present for so long, primary care physicians frequently misinterpret the condition, treating it as a stubborn, treatment-refractory case of standard depression. Meanwhile, a social feedback loop traps the individual in place. Friends and loved ones constantly remark that the person has just always been like that, validating the idea that the low mood is permanent. After 5, 10, or 20 years of operating in the gray, the psychological toll solidifies. The patient fully internalizes the disorder. The phrase, "I am sick," gets permanently rewritten as, "I am just a sad person." PDD represents a hostile takeover of a person's self-concept. The low mood is only part of the threat. The more enduring damage is the way it slowly replaces an individual's identity with a clinical list of symptoms. The reality, however, is that this deeply ingrained flatness is highly treatable. It is entirely possible to surgically separate a person's identity from their illness. This abstract flowchart illustrates a specialized intervention called CBASP, or the Cognitive Behavioral Analysis System of Psychotherapy. You can see the acronym acting as a wedge to intercept a closed, repeating loop. CBASP is uniquely engineered for chronic depression. It works by explicitly targeting the interpersonal cognitive distortions that keep that low mood locked in place. As the therapy takes hold, the broken loop untangles into a healthy, linear path, showing superior outcomes compared to generic talk therapies. When these targeted therapies are paired with correctly dosed pharmacotherapy, Along with behavioral activation and lifestyle adjustments, the success rates climb even higher. These clinical interventions function as a solvent, stripping away the heavy, suffocating filter that has obscured a person's true personality for years. If you describe yourself as a cynic or low maintenance, but secretly recognize that your daily inner life feels heavy, and if the phrase, "this is just how I am," runs on a loop in your head, it is time to challenge that assumption. If the I you are describing has been tired, hopeless, or muted for years, that pattern warrants a conversation with a licensed professional. Accessible, specialized screening is available without leaving your home. Coping and Healing Counseling provides 100% telehealth, insurance-compliant care across all 159 Georgia counties, with a team trained to handle chronic depression. Because you deserve to know who you are underneath the gray. Your personality is not your depression.